Today I'm going to review for you root canal treatment of a fairly calcified tooth number 14. I'm going to go step by step in how a case like this is managed using all the tools that we have at our disposal. Let's have a look at the periapical x-rays for this tooth. The first periapical reveals a calcified pulp chamber, and it also shows a large amalgam filling. The second periapical reveals about the same kind of anatomy, does not show much of a pulp chamber. The bite wing x-ray, however, reveals that there is actually a pulp chamber that is readily accessible. For this tooth, we took a cone beam CT scan, which in transverse section at the level of the CEJ reveals 4 separate canals, a separate MB1 and MB2, which, when looking at the apical third, reveals that MB1 and MB2 join, becoming one canal. Whenever feasible, I use a flat diamond disc to make a few flat spots to use as reference points during working length determination. Here I'm using a rounded end diamond burr to remove all decay and refine the prep and remove all discolored and questionable dentin. Now I switch to a 6 round burr on the high speed to finally finalize the prep and begin to access the pulp chamber. And soon you'll see, as we get closer to that mesiobuccal pulp horn, that it will start to show up under a little bit higher magnification here. We can see that very white spot near the mesiobuccal where the pulp horn is starting to show through. So now that all the decay is removed, we can see a little bit closer. We'll polish this up. I don't want to get into the pulp until all the decay is absolutely removed and we know we have as aseptic a surface as we can. And here we go. That is the mesiobuccal pulp horn. exposed. I will now go in with my chamfer diamond. I like to use that because it allows me to go down and laterally, and I'll open up the pulp chamber to gain my access for instrumenting those canals. Here we are using a microsuction tip to evacuate all the blood and liquid from the inside of the canal chamber, the pulp chamber, so we can have a good view of the orifices. There's the distal buccal, there's the mesiobuccal, there's the MB2, and now we're going to readjust, and we can have a good look around the pulp chamber, see what we're dealing with. I think if I had to do all over again, I probably would have done slightly, I may have slightly over-prepped the distal buccal there, but we'll see. We can blend that in with our final preparation. I'll use an ultrasonic tip here to help refine the axial walls of the cavity prep, and also to help locate MB2. This is a Buck 3 tip I use. I sort of use this as my go-to tip for almost everything I do. It's pretty versatile, and I think it does a nice job for the things I need to do. I always use water. Some people don't, but that's personal preference. I do because these tips are expensive, and I don't like heating up the tooth or the tip, so it works out okay. After I do my ultrasonic to refine the prep, I'll microsuction this out, and we can have a good look and see what the canal chamber looks like. And here we are. So you can see the pulp is still bleeding. This is one of the very important things about good anesthesia. At this point, when I'm going into that palatal canal, which is the most common one that patients will feel, I'll use a very curved, about a 45-degree curved hand file to get in there. But I'll also warn the patient that you may feel something here, so that if they do, then I can give them a little bit of anesthetic right away, and it's not a big surprise, and you can get that part over with. So here I'm using a number 8 hand file to work my way down the canals. You can see how it springs back. It's really hard to get video of the hand filing part because it's really hard to see. So we're going to irrigate this out. I've skipped a little bit of the sort of hand filing action to sort of expedite things, but now you can see that the canals are starting to develop a little bit with hand filing, and here comes the palatal nerve tissue coming out of there with the first rotary instrument. So we're going to see some rotary instruments. I use the Profile and Protaper system, sort of in a hybrid. That's the 1504 taper going into MB1 right there. And typically I will leave MB2 completely alone, and I'll illustrate why I do that later on down the line. Here comes the first Protaper, and I just never going and holding that. I just go in and out. One of the big rules I have here is either you're going in or you're coming out. There's no stopping, no lingering, no loitering, as I like to say. And we'll irrigate again. So here's a little bit higher magnification. You can see that the canals are starting to develop. We're going to work our instruments again. in or out, no loitering, no stopping. And I'm not forcing the issue, and I'm not really pushing it to get to working length. What I'm trying to do is open up a little bit of a pathway so I can get instruments down in there easier. Um, this is the 2007 Protaper, which I like for the mid-root shaping. And you can see I'm not forcing that down, I'm just kind of going straight in and straight out. We're always going to replenish and flush out all this debris. So with sodium hypochlorite, I'll flush out the pulp chamber and removing all that debris. Next up is my 2504 profiles. And again, you can see that I'm leaving MB2 alone. Next is my 3004 profile. And again, I'm not forcing anything down. We just kind of go and get a little bit of shape, because I actually use this to give my Gates Gliddens a little bit of room and direction on glide path. So we use this microsuction tip, dry everything out, and have a good look. And you can clearly see MB1, distal buccal, and palatal will be there on your right. And now we're starting to see some shape. And this is the Gates Glidden 2. Again, it's hard to see this under the microscope because I don't have good access, but I'll always push these to the outside the line angle, and you can see that one broke. And they break frequently, but that is not a big deal because they're designed to break away from the tip. So they'll break, and that's okay. Go get a new one and move on. You can hopefully see that I'm actually using them to brush, in this case, the palatal canal buccal and lingual, to open it up a little bit in that direction, and then the mesiobuccal, I'm going to use it and bend it into the line angle to help keep away from that furcation. Okay, so here comes Gates Glidden number 3. Again, you'll notice I'm not pushing it down, I'm just brushing side to side to help give me a little more access with the orifice and give me some straight line access. Some people do not recommend this technique anymore, and they're recommending with just all nickel titanium instruments, and I just don't love getting close to the furcation, and that's why I use these things, because it gives me a little bit of control over what part of the dentin I want to remove, and to me that's pretty nice, and it gives me a little bit more control. But to each their own, and people get some really great results not using these instruments as well. So next we're going to just irrigate this out, and we have a good look at the 3 main canals. Okay, so here we go. This is probably the thing that most people ask about is what do you do with MB2? So now I've instrumented the other three canals completely. They're ready to go. Now I know there's that line along the between the mesiobuccal and the palatal canal, and usually we can find MB2 there. You can see I've got a curved number 8 file, and I'm very gently working that in, and that slipped into MB1, and there it is. You can see MB2 right there, and you can see the angulation that my file has. It's going to the distal and the buccal. So that is a little bit of dentin that we're going to have to remove to get a straight line angle, and we have to be sure that this is not something that we can sort of horse and drive a file down the first attempt. So you can see how gently I'm using this number 8 file in a watch winding motion, and always give it a pull back to make sure that it's not buckled over. But that's it. There's no magic, man. This is actually just tedious labor. So that's what it looks like when we're doing it. Trying to get the camera oriented so you can see, but basically I'm not turning that file in too many directions, and when it binds I give it a little pull back, and I've got my working length set on that stopper, and it looks like we're making some progress down there. Now mind you, if I'm ever getting down MB2 this quickly, I'm always suspicious that it joins MB1, because typically MB2 is not so easy to get down with one pass like this. Usually it takes a little bit of recapitulation with a bunch of different instruments to get down there. So already in my head I'm thinking, okay, these things join. Now we know they join in this case because we had the benefit of the CBCT at the beginning, but it's you know, this is without the CBCT, this is the kind of thing you look for. Is if you fall down after the first half, suddenly the file seems to fall into MB2, you can have some hope that they may join actually. So we're going to proceed here and continue with a number, this is a number 12 file, and I always like to have, I have 6, 8, 10, 12 and a half, 15, 17 in my sponge at all times, because I like to go up in small steps. Going from a 10 to a 15 is a 50% jump, and it's a great way to break a file in one of these little canals. So yes, I still use these kind of files, and I do hand filing. So here we're going to continue instrumenting MB2, and I use a step back technique. That's the 04 profile. Then we go to the purple protaper, then the yellow profile, yellow protaper, and red and blue profiles for the final shape, but I don't do these in one go. I'll make some space, and the next one will fall a little bit farther down, and then I'll go back to the beginning and go up and down the series as many times as it takes. You must be patient with this. After I get that initial coronal shape started, I will use the Gates-Glidden drills to sort of get me a little bit more straight line access, so we don't have to make these files go around too many turns, because they don't like that and they will then fracture. So that's what I'm showing now. Once this is done, we'll get to the opening of the orifices with the gates, clins, burrs. So here I come with the number 2 gates clin, and you see, it's hard to see, but I'm bending it to the mesial portion of that orifice, so to avoid as much of the furcation as I can. You'll see the difference after we're done using the number 3 and just a little bit with the number 4 to brush up that mesial aspect of the canal, that we have much better access for our instruments to go in, and they're dropping in a straight line instead of from the distal like they were before. I never like to have them drop in from the distal, because I know these canals usually turn back to the mesial, so again, we're putting these files through a lot of stress if we do that. And there are a lot of people who like to make these micro accesses and do that. I just don't love it because I don't get as predictable results with it. So here you're going to see a microsuction MB1, and voila, MB2 empties out. And so when I see that, it's a pretty clear indication that usually those things join. And actually, I like to suction that out numerous times to get all the debris from between the two out of there, out of those fins from between MB1 and MB2. But so when I see that, I know that MB1 and MB2 now join. It confirms what I saw on the cone beam, so I'll pump some disinfectant into MB2, cycle it through MB1, and it makes for a really nice clean canal. So that looks great. Now we've irrigated and cleaned all 4 canals. I'll use the microsuction to suction out every canal. One of the downsides about that microsuction is that if you get too close to the apex, it can start a little bit of bleeding, which you've seen there. So you have to be mindful of that so you don't create a seal and start the apical bleeding. At this point, we're going to do a little refining of the prep, and then we're going to get ready to fit gutta percha cone. So even though we know that they join, usually I will just clean and shape the MB2 just to make sure I haven't left any debris behind. So you'll see here we'll take the final instruments and go through all the canals and refresh that hypochlorite to make sure that it's removed all that dead tissue or dying tissue in there, and dissolved all the vital tissue in there as well. And so we're going to just finish up instrumentation, and then we're going to move on to gutta percha cone fit. So here we're going to do the cone fit, and I use non-standardized medium and fine medium cones typically. I usually fit the main canals first, and then I will fit MB2. I know that those two join, so I expect MB2 to be actually shorter than MB1. And then we'll take a X-ray to see how those turned out. So the cone fit X-ray shows that the cones are right at the radiographic apex, so I will cut those back about a half a millimeter. The palette hole looks to be okay, and so now we're ready to cut our cones back and dry and seal our canals. So as you can see, using medium and coarse paper points, all the canals will be dried in preparation for sealing with gutta percha and Kerr sealer. And when we do this drying, you don't want to go past the apex with these cones because it can actually cause some bleeding. We see, there might have been a little bit of blood at the end of that one, so I'll just dry that all out. Now, with this glass cone, we are ready to seal. Here I come with the cone for the, I think it looks like it's the palatal canal. We're in there, trying to focus the microscope. Going to get it right down to the apex. Very small amount of, I wouldn't call that a pump, I just go in and out once. I'm going to take my system B tip and just give some even pressure so I can get down probably within about 5 millimeters of the apex. I don't fight for 5 millimeters or 3 millimeters or whatever everyone's doing. I just get down to what's reasonable, and as long as I'm, well into the apical third, I'm happy. And then we'll pack this sort of with my hand condensers. and we'll proceed with all the other canals. Moving on with the distal buccal canal, the story is the same. Gently put the cone down in there, maybe one little up and down motion, that's it. We're not trying to pump a bunch of sealer out into the patient's bone and periodontal ligament, cause a whole lot of inflammation and problems. Back it down. Use my pluggers to nicely flatten that out. Now we're going to move on to the mesiobuccal canal. You always have to have one in mind to which one you're going to pack first. In this case, I choose the mesiobuccal 1, and I put my cone in there. Again, the one little pump, put a little sealer in MB2, and then we're going to proceed with the cone for MB2 as well, and that does not really have to be pre-fitted, but I had pre-fitted it, so because it joins, it worked out well. So I'm going to just sear them off first. I sear off MB1 and then I pack MB2, and then I come back and pack MB1, and you can see the sealer bubble up into MB2 as I do that. So that gives us a sense that even though there was gutta-percha there, there's still some communication between those two canals, and that's why we get the fluid movement from MB1 into MB2. We'll pack these down, and then we're going to go on and backfill them with my element system. And you'll see I go into the distal buccal canal first, because I don't have to bend the elements one to get into the distal buccal canal. And usually I do have to bend it to get into the mesiobuccals. In this case, because the tooth was so broken down and there was such a big filling, I don't. But when I do, I will use, I'll put some in the palatal here. When I do need to bend the tip, I just use the wall of the tooth to push it like that. That way you don't have to come out of the mouth and get back in the mouth and use some tool to bend it. Just use the tooth to bend it. We'll backfill like this, and then we'll use our condensers to just flatten off the top. So here I'll use the System B tip to remove any excess gutta-percha. And what I've adapted to doing with the alcohol, some people put cotton balls in alcohol and use those. After I pack everything down, what I'll use is just have a 12mm syringe with a brush tip that's full of ethyl alcohol that we'll use to start cleaning out this pulp chamber. And that's just a quick, effective way to do this. And it kind of speeds the process along, and I like it much better than trying to do it with single pellets of alcohol-soaked cotton. So here I'm going to prepare post space. I do not like to prepare very wide post space. This is a number 3 parapost. I do not like to dig into the canal walls. I try and give it a little bit of length for retention rather than to make it a really big heavy post. So I prepare post space with the post drill. We're going to fit a post and cut it and get ready for cementation. Okay. I'm going to clean that cavity out one more time with alcohol, make sure it's minimal sealer around. Microsuction. This microsuction tip is handy for so many things. It's really great. You can see how sort of bone dry it makes it in just a few seconds. It's attached to my high-speed handpiece. There's the number 3 parapost being fit. I'll take it out, cut it, and at this point, while they're mixing, I will etch and prime and bond everything so that we can do this in a most expeditious manner. So I'm going to actually make a little more post space. I didn't like how shallow that was, so I actually made a little bit of extra post space to see if I can get a little more retentive post in there so it wasn't just floating in cement. And there you go. So now, while their assistant is mixing the post cement, I etch the tooth structure, we'll rinse, and again that microsuction comes in great alongside with the high speed evac and the air. You can see how quickly everything is really well dried. So at this point we're completing the rinsing out of the etchant, and I'll prepare to bond the tooth structure, and we're going to switch the light to a bonding light, composite light, and again please forgive the poor angulation of the microscope, so it's hard to see, but I'm just bonding the tooth structure. We're going to proceed to cure that, and that's what she's doing now. It's hard to see. Now that that's cured, my other assistant is mixing post cement for me. So out goes the curing light, in comes the post cement, expressed through one of those delivery needles right into the canal, making no voids, and the cut post is inserted into the canal, and that looks great. And now I typically don't even wait for that to set all the way. Right now the assistants are mixing my composite for the build-up, and I just kind of get that thing seated in all the way. And while that's setting up, I'll just let composite flow around it really nicely. And I use the endo sequence composite. I've just started using that over the last few months. I just love how it flows and how it cuts, and it's really just a very nice material. So we're going to have a look at that, and then we are ready to do our composite buildup. So my assistant is ready with the buildup, and here it comes. You'll see how well this material flows. It's important to me to get it right around the post, because I don't like the look of a void on the final X-ray if possible. And I also like to, I used to use the blue composite materials for some of these cases when it was deep subgingival or some sort of a difficult margin to reach. But I had some of my referrals say that it gets in the way of them using porcelain crowns. So now when I want to use a different color, I'll use this super, I think it's called Opacious White by Endosequence, which Rassler makes, and I think is a really nice material. So now that's all cured, and we are ready to just make some final adjustments to the composite, smooth it out, and I'll use some various diamonds to do that. Little football diamond, and we set that up, remove the clamp, and check the bite. And then we'll take some final x-rays. So here we have the final x-rays, and we can see that the 4 canals are well condensed. The post looks reasonable. It does not look to be digging into the canal walls, but it appears to have enough length for retention. The patient did great, and she's now ready for final restoration.